So let's go ahead and talk about calcium channel blockers. I will address these calcium channel blockers again when we talk about the two that belong to the type 4 antiarrhythmics. So if you do not feel like you grasp these initially, don't worry. We will see them again. The main difference between the dihydropyridines and the non-dihydropyridines, so again we have our dihydros and our non-dihydros. So the main difference between these is that the dihydropyridines will equally inhibit calcium channels present in the smooth muscle as the myocardium, while the non-dihydropyridines tend to favor the myocardium much more than the vascular smooth muscle cell calcium channels. So our non-dihydropyridines are verapamil and diltiazem. These prefer to bind voltage-gated calcium channels that have already been depolarized and are open, but the inactivation gate is closed. Remember, we have an inactivation gate that is open and an activation gate that is closed when the cell membrane is ready for a depolarization. A depolarization comes along and opens the activation gate. The inactivation gate remains in the position of open. Calcium will rush into the cell and eventually the inactivation gate will slam shut. So in this position we have no more flow because the inactivation gate closed, and this blocks any more calcium influx. These non-dihydropyridines, verapamil and diltiazem, like to bind channels that have already been depolarized. Therefore, they block the repolarization phase of areas dependent on calcium conduction current, which are particularly high yield to know, which are the SA and the AV node. So verapamil and diltiazem will sit inside of these calcium channels and bind ones that have been frequently depolarized. That is why they favor areas that are constantly being signaled to depolarize, and that's why they're particularly helpful for controlling areas of unwanted continuous cell depolarization. As you can see in your first aid text, verapamil is the most selective for the L-type calcium channels in the myocardium, which is closely followed by diltiazem. So the dihydropyridines all end in D-I-P-I-N-E, and this makes sense because they are dihydropyridines. So dipene is a great way to identify which ones are belonging to this particular group of dihydropyridine calcium channel blockers. They actually favor the vascular smooth muscle calcium channels just a tiny bit more than the heart. So that's the way you should think about it. You should think dihydropyridines are for blocking vascular smooth muscle cell calcium channels, while the non-dihydros are for blocking cardiac, particularly verapamil, with diltiazem a somewhat equal efficacy at blocking the myocardial and vascular smooth muscle cell calcium channels. So, for example, amlodipine would be a dihydropyridine. It ends in D-I-P-I-N-E, and they all do that. So, if you want to treat Prince-Metal angina and Raynaud phenomenon, what type of calcium channel blocker would you prefer to use? Would you like to use one like verapamil that has high cardioselectivity, so it prefers the calcium channels in the myocardium? One like diltiazem that has medium selectivity for the myocardium and vascular smooth muscle cells? Or would you go with one of the dihydropyridines that mainly antagonize at the level of the vascular smooth muscle cell? I'm pretty sure that all of you guys would select something like nimodipine. Ends in D-I-P-I-N-E, it must be a dihydropyridine. Remember, we want and need dihydropyridine because it loves inhibiting the calcium channels on the vascular smooth muscle cells of the vessels that we are interested in, instead of the myocardial calcium channels, because Prince-Metal angina and Raynaud's is a problem of vasoconstriction of coronary and digital arteries. So remember, Prince-Metal and Raynaud are both a problem of vasospasm. We do not want these vessels to vasoconstrict randomly like they're doing, particularly in Prince-Metal angina with the coronary arteries, and Raynaud's with the arteries that supply our fingers and hands. So Prince-Metal is a spasmodic-like vasoconstriction of the coronary arteries that causes transmural ischemia. It affects all levels of the myocardium because there is vasoconstriction of the coronary artery that runs in the epicardium. Remember, these send perfusing branches down through the myocardium to the subendocardium, but do not supply the endocardium because that is supplied by the blood within the chamber itself. So it is transmural ischemia that occurs with Prince-Metal angina, and you must give them a calcium channel blocker that is specific for these vascular smooth muscle cells that are contracting within these coronary artery lumens. This is a super high yield moment, and that is the association of nimodipine, which is also used in the treatment of a subarachnoid hemorrhage. So it ends in DI, PI, and E. We know it is a dihydropyridine, which means it must like to bind calcium channels in vessels. So you guys know it's coming, right? Review time. Mainly because I just finished neurology and we saw about 3 subarachnoid hemorrhages a week, this is actually a super high yield clinical and academic point for your exam because it can kill someone if you do not recognize it. What can you tell me about a subarachnoid hemorrhage? Remember, there are 3 levels covering the brain. The dura, which is a tough layer, durable, dura, followed by the leptomeninges, which are the, arachnoid, and it is called arachnoid because of the presentation of this layer that looks like a spider's web, followed by the pia, which is a very tight adhesive layer directly on the brain parenchymal surface. A subarachnoid hemorrhage must indicate that some sort of vessel, which are actually the bridging veins, damaged by some sort of head trauma, or in the case of a step 1 question, due to tension caused by brain atrophy in an Alzheimer's patient. So these bridging veins burst directly under the arachnoid layer and cause accumulation of blood in the subarachnoid space. So under the arachnoid must mean right here, in the subarachnoid space, because the pia is directly adherent to the brain surface, the arachnoid is the next layer up, and the dura is the last layer. So why should we worry about cerebral vasospasm and give someone nimodipine? Well, we rupture these bridging veins here in the subarachnoid space, and there are actually vessels running in this area as well that are not bridging veins. So if you have something very irritating or caustic like blood surrounding these cerebral vessels and not actually inside of them, you can cause vasospasm because you irritate those vessels. They are living structures. So you can give the dihydropyridines or the non-dihydropyridines for someone in the situation of hypertension because it'll help decrease the risk of this vasospasm and drop blood pressure. Your dihydropyridines will tend to drop blood pressure in a different way, mainly by arteriolar vasodilation, while your non-dihydros will tend to cause a decrease in cardiac output by decreasing the heart rate, because they decrease the depolarization rate in areas of the heart such as the SA and the AV node that are particularly dependent on calcium conductance for automaticity. So again, our dihydros, which all end in DI, PI, and E, tend to favor the vascular smooth muscle cells, and the non-dihydros, such as verapamil and diltiazem, tend to favor the calcium channels that are particularly in high amounts in areas such as the SA and the AV node that are dependent upon calcium influx for depolarizations. So for dihydropyridines, we cause a decrease in total peripheral resistance, which causes a decrease in blood pressure. And for the non-dihydropyridines, we cause a decrease in heart rate, which causes a decrease in cardiac output, which is a component of our blood pressure equation, which means that we decrease our blood pressure. The toxicities associated with these drugs are directly related to the mechanism of action of the drugs. For example, cardiac depression and AV block should be rather obvious to us because we are directly blocking the calcium channels that are responsible for the intrinsic depolarization rate of the heart in areas that set the heart rate, such as the SA and the AV node. Do you see here that if we block these calcium channels and decrease the slope of the upstroke for our pacemaker cells, we can have a decrease in heart rate. Also, we discussed how the verapamil and diltiazem prefer to bind calcium channels that are being depolarized very frequently. They will bind to the inside of the L-type calcium channels and prevent them from restoring to their normal state, which causes a prolonged repolarization at the AV node. Now, the side effects related to these drugs are also directly related to the mechanism of action. The peripheral edema, the flushing, the dizziness, they're all related to the vasodilatation of the vasculature. If you heavily dilate your vessels, you can cause fluid to shift across the vessel wall. The flushing is because your vessels are actually going to now be closer to the skin surface when you cause severe vasodilatation. And this will cause a release of heat in a very red color because that vessel is now closer to the surface with that oxygenated blood. The dizziness is a combination of a drop in the cardiac output and total peripheral resistance, which can result in decreased forward perfusion to the brain. And this can give you mild hypoxia, which causes episodes of dizziness. Now, the hyperprolactinemia has recently been elucidated in the last couple of decades, and it classically occurs with verapamil. So let's review some more because we're kind of on a roll here. So let me just quickly remind you about the hypophyseal portal system. Remember, there's the hypothalamus up top, and we have our posterior pituitary and the anterior pituitary. And these are connected by a hypophyseal portal system. There are also direct projections from the hypothalamus to the posterior lobe of the pituitary gland. So these are direct neuronal projections. And then there's also a portal system that is fed by the superior hypophyseal artery, and the inferior aspect of the portal system is fed by the inferior hypophyseal artery. So these structures release blood. So these structures here release components into the capillary system. It travels down this capillary network into the anterior and posterior pituitary glands. So the arcuate nucleus in the medial basal hypothalamus, so the medial part and then the basal part of the hypothalamus, has neuroendocrine neurons that produce dopamine. They package it into vesicles and release it into the superior hypophyseal system, which then joins the capillary beds that eventually will reach the adenohypophyses, which is the pituitary gland, particularly the anterior pituitary gland. The binding and release of these dopamine vesicles to stimulate lactotrophs. Remember, lactotrophs are present in the anterior pituitary gland, lacto being milk and trophes being growth. So these dopamine vesicles must be released onto the lactotrophs. These dopamine vesicles are dependent on calcium influx into those neurons for release. So verapamil can actually inhibit the vesicles from releasing dopamine within this hypophyseal portal system. And if you're not allowed to release dopamine onto these lactotrophs, then you're not going to be able to inhibit the lactotrophs with dopamine. If you lose this inhibitory effect of dopaminergic inhibition, then your lactotrophs will go crazy, and they will just start cranking out prolactin. And that is how you get symptoms of hyperprolactinemia with verapamil. So the constipation is associated with the calcium channel antagonism of very special cells in the gut called the interstitial cells of Cajal. Remember, these dictate the baseline depolarizations of the intestinal smooth muscle. So if you block these with a calcium channel blocker, then you can obviously have signs of constipation.